Today is our 10th edition, and it's a very, very important day. And I take this opportunity to wish all the gurus and the teachers in front of us a happy Guru Purnima. As the Pratan goes, Guru Brahma, Guru Vishnu, Guru Devo Maheshwara, Guru Sakshat Parabrahma Tashmai Shri Guruve Namaha. I think today being our 10th edition, and it's been successfully helped us to do this program and reach the 10th edition. So I really thank Dr. A.K. Balla and Dr. Ranaji for helping us to coordinate the entire team of Gangaram Hospital to initiate this activity and continue to go in a good speed and rhythm with good levels of noise getting created for the benefit of all the students. I think the entire community of Nephro students would be highly benefited to all the gurus in front of us for having helped us to sustain this activity for a more number of programs. So I welcome Dr. Balaji. I request you to kindly introduce the moderator, the external examiner for the day, and help us take this program. Dr. Balaji.
Thank you, Microlab, for helping us in continuing with this bedside discussion teaching, and especially focused on exam going students. And on behalf of Department of Nephrology, I welcome Dr. K. Sampath Kumar. He's head of Department of Nephrology at Meenakshi Mission Hospital and Research Center, Madurai. He is a very, very experienced examiner and very good clinician and excellent academician. And he has vast experience and has very active program, national board program at his center. And the candidate who will be discussing the case is Dr. Ravi Ranjan. He is a DNB exam going student at RNT Memorial Hospital, Kolkata. Over to you, Professor Sampath Kumar.
Yeah. Good morning to all of you.
Yes.
At the outset, I would like to thank Professor Balla and Professor Rana for this great opportunity to interact with the young minds. I think without wasting much time, we'll go ahead with the case discussion.
Thank you, sir. Good morning. I'm going to discuss a case. This is Mr. Patient, Mr. X, a 23 years old male from Howrah, West Bengal. Is educated up to class 10 standard. Worked previously as goldsmith in Kerala. Admitted in our hospital on 28th of June and examined by me on 2nd of this month. And informant was patient self. He is a known case of renal alopecia of SCPM who underwent life-related avio-compatible renal transplant in April 2019, admitted with complaints of progressive graft dysfunction for last 3 weeks and painless hematuria for last 2 weeks. I would like to date back my history in the year 2017 when he was 17 years old. He was apparently all right prior to May 2017. He was non-smoker, non-alcoholic, and not known to have diabetes or hypertension prior to that. In May 2017, while being evaluated for acute febrile illness, he was found to have a renal dysfunction with a creatinine level of more than 10. He was told to have he had a leakage of protein in urine and leakage of blood as well. And he also had bilaterally small or contracted kidneys on evaluation. He was diagnosed to have hypertension this time with a blood pressure of 160 by 100 millimeter of mercury. He was initially started with 2 medications, the name of which he could not remember, with which the BP was apparently controlled. There was no history of previous upper or lower respiratory tract infections, skin infections, or any other localizations for the fever. Fever subsided after 5 to 7 days with only conservative management. There was no history of any pedal edema, clotting of urine, hematuria, rashes, or shortness of breath. No history of prior intake of any nephrotoxic or drugs or alternative medications or over-the-counter drug exposure. There was no history of childhood recurrent UTI, no history of double voiding, frequency, urgency, hesitancy, and urinary retention. There was no history of any sexual promiscuity, jaundice, blood transfusion, rash, joint pain, oral ulcer, photosensitivity, claudication, and muscle pain. No history of any hearing or visual abnormalities or gait abnormalities. His growth was as per his peers, as informed by him. He had average scholastic performance. There was no history of any complications of hypertension in the form of headache, blurring of vision, seizure, loss of consciousness, chest pain, and there was no history of any loin pain or passage of stones in urine. He was advised for renal replacement therapy in the form of hemodialysis at that point of time, but he refused and he came to West Bengal. Over the next 4 weeks, he developed progressive bilateral pedal edema, and there was significant reduction in urine volume and frequency. He also had generalized weakness, easy fatiguability, exertional dyspnea, and nausea. On evaluation here in West Bengal, he was found to have a creatinine of 18 mg per dl and was initiated on hemodialysis to temporary neckline access. Later on, a fistula was created in the left forearm, and he was maintained on twice per week hemodialysis, which was continued for next 1.5 years. He had few episodes of intradialytic hypertension and shortness of breath interdialytic period. Therefore, his frequency of dialysis was increased to 3 per week. There was no other dialytic complications. He was managed. Managed to maintain a stable post-dialysis dry weight. He required 2 units of blood transfusion during his dialysis vintage. He received hepatitis B vaccination during this period, and his residual urine volume reduced from 1 liter to less than 200 ml over the period of 1.5 years. In April 2019, he underwent a live donor-related avio-compatible renal transplant with mother as donor at her age of 45 years without any prior comorbidities like hypertension or diabetes. He received some costly medications during the transplantation, was probably ATG as induction. He was maintained on 3 immunosuppression medications, tacrolimus, mycophenolate, and prednisolone. He also received some prophylaxis for infections. He had good post-operative graft function with a discharge creatinine of 0.9 mg per dl and was discharged on 10th post-operative day. Post-transplant, his blood pressure remained well controlled with only a single medication. He was asymptomatic and had a near stable graft function over the next few months. His creatinine went up to 1.4 mg per dl about 3 months back without any significant protein loss or blood loss in urine. His tacrolimus level was 8 nanogram per ml at that point of time. He continued on those same medications with some adjustment of doses. On routine follow-up 3 weeks back, he was found to have a higher creatinine of 3 mg per dl without any symptoms. For last 2 weeks, he is having some painless hematuria without any fever, burning sensation in urine, or pain over the graft site. This time, his tacrolimus level was 6.5 nanogram per ml, and his creatinine increased to 6 mg per dl after hospitalization. But he was having good urine output of around 1.5 to 2 liter per day with persistent hematuria and no history suggestive of any volume overload. After hospitalization, he underwent a graft biopsy, which was uneventful. Post biopsy, he received 3 doses of IV injections on 3 consecutive days, and his mycophenolate was stopped, and he was initiated on a new drug which was called induction. Regarding the family history, he doesn't have any family history of diabetes or hypertension or renal dysfunction in the family. His bladder, bowel, sleep, and appetite are normal, and he used to take mixed diet of around 1800 kilocalories per day. So, this is the history, sir. Hello.
Yeah. So this is
Yes,
a fairly comprehensive and typical history that you get in a patient who gets admitted with end-stage renal disease in the second or third decade of life, which is a tragedy in India. So we'll start with the initial part of the clinical presentation. You said that this patient had presented initially with fever with red colored urine, isn't it? Was there a history of hematuria?
Sir, there was hematuria, but it was not macroscopic, it was microscopic. He was told that he was leaking protein and blood in urine on evaluation.
Okay, so, so what importance can you give for this fever that at presentation that he had?
So,
Was it a very high grade? What type of, yeah.
Presentation was like that of a glomerulonephritis or nephritis syndrome. Though we at that point of time we didn't know that whether this is acute kind of presentation or a chronic. But if I should think in a line of acute glomerulonephritis, and the fever that can suggest that this can be secondary to some infection, that is infection-related glomerulonephritis at that point of time, or some glomerulonephritis that can occur after some infections like upper or lower respiratory tract infections like IgA nephropathy or some CCGN like that.
So when you have presentation with fever and renal failure, the possibilities that will run through your mind will be initially an acute process, like acute glomerulonephritis, as you have told. And also immunological diseases also should be considered when you have a patient who presents to the nephrologist with fever and renal disease.
Yes,
so among the two considerations, could you consider end-stage renal disease as the presenting manifestation of a disease?
Yes, sir. Sometimes IgA nephropathy can present in the directly, they land up directly into the end-stage renal disease.
No, what physical findings that should make you, before the ultrasound reports are available, what physical finding which will make you suspect that it is not all acute onset, it is a chronic process? What are the physical findings that you will look for?
This patient was apparently asymptomatic in spite of having the investigations saying that it is glomerulonephritis. So apparent asymptomatic patients usually do have a underlying chronic kidney disease and the process is going on for a long duration. Other than this, the patient should have uremic symptoms in the form of nausea, loss of appetite, and some.
See, nausea and loss of appetite do not differentiate between an acute process and a chronic process. So, what are the typical physical findings?
Presence of pruritus or polyuria or nocturia that can help us in.
No, you said there was no history of polyuria or nocturia.
Yes.
Pruritus also was not there. Supposing you say the patient denies that there is pruritus, and you want to make a physical finding which will make you suspect there is pruritus. What is it?
The scratch marks over the skin which are present, or on clinical examination if there is some sort of peripheral neuropathy.
These two may not be very useful, but you should have a good look at the nails. If you find that the nails are very shiny, like as if a polish has been applied to the nails, that will tell you that the very shiny nails will give you a clue that there is a long-standing pruritus. What about other physical findings which will make you suspect chronicity?
like the other than the pruritus, chronic nail changes that can be half and half nails or the
No, what will be first thing which will strike you?
As the patient is chronic kidney disease.
Unusual pallor. Pallor is a very important thing. So it cannot be explained by any external blood loss or anything. That will give you a clue that there is a possibility of a chronic disease.
Yes.
Then, if you have
hypertension,
if you have an interstitial disease which has been going on for many years, what are the physical findings which will make you suspect an interstitial disease?
This kind of patients with chronic interstitial disease will have a significant anemia compared to that of the chronic glomerulonephritis. They have lesser amount of hypertension. They are more acidotic and having acidotic regime. And on exertion, they will have complaining of shortness of breath or indefatigability, tachypnea on examination.
That may not be very differentiating. What else? What else is very
and presence of mineral bone diseases, like the patients will complain of pain over the back.
No, more than the aches and pains, it will be the bony abnormalities in the form of genu varus, genu valgum, knock knees.
Yes.
All these will make you suspect that it is a growth failure. All these will make you suspect that this could be a long-standing disease. So none of this will be positive in many of our patients that present to us with an advanced renal failure in India, which is a tragedy. So they will even after practicing for many decades, you will find that you will have difficulty in differentiating whether a patient who sits in front of you has got an acute or a chronic process. So this is where you will have to take recourse to the laboratory diagnosis. So what are the laboratory diagnosis, laboratory investigations which will make you suspect a chronicity rather than an acute process?
So again, the presence of anemia, low hemoglobin, and there will be, unless it is a nephrotic syndrome, it's a low albumin level, or and as well as hypocalcemia, hyperphosphatemia, hyperuricemia, and all these points towards chronic kidney.
Okay, so these are the things that you should think of, and then go ahead with the ultrasound. Ultrasound showed bilateral small sized kidneys, isn't it?
Yes, sir.
Yeah. So what in such a patient comes to you, what are the decisions that you will take for dialysis? This patient was ripe for dialysis. Was he having all features suggestive that he had to be put right away onto a dialysis program?
Yes, sir, I think so, because the patient has a very high creatinine of 18 mg per dl, which corresponds to a GFR, which is probably less than 5 or 6. And on top of that, patient was having all features of volume overload. He had bilateral edema, he had shortness of breath on exertion, and probably suggesting towards volume overload status. And there was some uremic symptoms at that point of time, which are definitely indications of health.
Okay. So what about the commonest dialysis access that you create in a patient who comes to you like this?
We used to prefer the right-sided tubular line, right internal tubular line. That is a temporary line, usually uncuffed, when we used to give urgent hemodialysis to our patients.
Okay, so he was taken up for that, and then was a permanent access created?
Yes.
So what was the permanent access which is created?
For this patient, he was having a left radiocephalic history.
Okay. And he was on dialysis for 1.5 years. So it could. So what are the problems of in these 1.5 years that he has had?
he had some episodes of shortness of breath suggestive of pulmonary edema and also interdialytic hypertension.
Yeah. Tell me about this intradialysis hypertension. What is this phenomenon?
So, usually some patients, around 5 to 15% patients can have interdialytic hypertension, which is the systolic blood pressure of that increases more than 20 during the process of dialysis, and they have it around the second or third or fourth hours of dialysis, and these patients usually have a poor compliance to their salt and water restrictions. It's mostly because of the volume overload, almost in 90% cases, but in some 10% cases that can be secondary to some activated renin-angiotensin system or sympathetic activation. These patients can also have sympathetic inactivity or overactivity, and they can have some drugs of antihypertensive drugs which are probably dialyzable. So these patients have rising blood pressure during the
Okay, good. So, how do you diagnose hypertension in a hemodialysis patient? When do you say that a hemodialysis patient is hypertensive? What level of systolic blood pressure? When do you measure the blood pressure? And when do you make a diagnosis? This is the ideal time to measure.
During that should be done in pre and post dialysis, or in fact during the dialysis period. That if the patient is unstable, that should be checked. Blood pressure should be checked at every 15 minutes to 15 minutes interval, and if the patient is stable, we can take it 30 minutes to 1 hour interval. And other process like home blood pressure monitoring or 24 hours ambulatory blood pressure monitoring.
Is it 24 hours or something else? The gold standard is 44 hours. Okay.
44 hours.
The gold standard of making a diagnosis is 44 hours, which is very, very difficult. It is like measuring an inulin clearance. So it is not possible to have the 44 hours ambulatory blood pressure monitoring for every one of our patients. So they have tried to correlate. That is a beautiful article which was done by one Agarwal, who has done a lot of studies in dialysis, hemodialysis hypertension, where he has measured he kept the 44-hour ambulatory blood pressure as the gold standard or reference value, and then he checked the pre-dialysis blood pressure, the intra-dialysis blood pressure, and the post-dialysis blood pressure. So what he has concluded is that the median midweek intra-dialysis blood pressure is the ideal method in the clinical practice, because you need to have a clinical guideline. You can't have 44 hours ambulatory BP. So anything above 140 in the median, supposing he is on weekly thrice hemodialysis, the Wednesday median intra-dialysis blood pressure systolic above 140 has got a very high sensitivity and specificity, more than 80%, of making a diagnosis of hypertension. So in this patient, you said that about some drugs, antihypertensive drugs, which could be dialyzed out. So can you tell me the common antihypertensive drug which is a dialysable drug?
Common antihypertensives are like diuretics or beta blockers like atenolol or metoprolol, and if it is a
what is the dialysability of atenolol?
Not sure.
So atenolol is not a very well dialysable drug, and it can be given weekly thrice. So you can give 25 milligrams or 50 milligrams of atenolol, and the half-life of atenolol is prolonged. So you can give this, and this is a good drug which Agarwal is very favorite drug of Agarwal is atenolol, but it not many takers in Indian context. We always go by the calcium channel blockers. We always go by the centrally acting drugs for the hypertensive control. As you correctly said, the most important aspect of the hypertension control is the salt and water restriction. So how do you ascertain that a given patient is salt overloaded in hemodialysis?
By if there is symptoms of shortness of breath or edema, or if there is, if on examination, if the patient is having edema, or if the patient is having tachycardia or any galloping or bilateral catheter raised JPT, or if the hepatotubular reflux is present, and by some investigations that can help us in this, like if there is increased NT-proBNP level, or if we do a bioimpedance test, or by taking the IVC measurement by echo.
So all these will tell you that there is a sodium and water excess. And somebody, you may be surprised that many of these patients may not even have edema, and but will have sodium and water excess. So what is the next step of treating these people? What will you do? What will you ask your dialysis technician to do?
Okay, so we'll gradually reduce the post-dialysis dry weight over the period of time, and we'll at the same time we'll avoid intradialytic hypotension, and that can be done by either by increasing the frequency or by increasing the time of the dialysis period, or at the same time we'll take the ultrafiltration which is being given, and that can be changed into gradually decreasing ultrafiltration or gradually decreasing sodium. So that is known as the ultrafiltration profile, or sodium profiling of this patient. So that can be done to ensure.
Okay, so you need to produce a slow and sustained reduction in the dry weight and see whether the blood pressure comes under control. You started doing it, and after 2 weeks, there is no response. The blood pressure continues to remain high. So what will be your thoughts?
I'll ask the patients to take antihypertensive prior to coming to dialysis center, and those should be non-dialyzable medications, or we can add some other medications like midodrine or sertraline prior to dialysis.
See, the answer, I expected an answer from you saying that 2 weeks is too short a time to ascertain the importance of, or the usefulness of reduction of dry weight. There will be a time lag. The time lag will be anywhere between 6 to 8 weeks. You need to wait. You need to keep on reducing and see whether the patient goes in for a hypotension. Otherwise, slowly you will have to come down on his dry weight. There will be a lag time. This is important. So there will be a period of 6 to 8 weeks before the blood pressure will start coming under control. Okay, so now we have, he has been on dialysis for 1.5 years, and you said his mother is a willing donor. So why has it taken 1.5 years for us to say yes?
That was probably because of the financial reason only.
Okay. Right. So are you happy with the choice of the donor in this patient?
I am happy in the term that this was haploid match, and there was ABO compatibility in this.
Supposing at the hindsight, this patient is having a recurrent disease, And what if had you known that there was a biopsy proven disease which could recur on the
Familial.
graft, so would you have said no to this donor?
So in certain situations, if the disease is familial, they can and the patient donor can have the disease after the donation. So that from donor's point of view, that is a concern. And in recipient's point of view, that there is a chance of recurrence in post-transplant period, that is also a concern. But as the patient is already 45 years old and not having any hypertension, diabetes, and any renal involvement, so I'm happy to take the
Good.
mother.
So that is how you should argue, because at present context, this is the best way to go. So recurrent glomerular disease or no recurrent glomerular disease, this is the way to go in the present circumstances when you have a haplo-matched mother who is coming up. So what are the pre-operative precautions that you will take in this in a situation like this, as far as the donor is concerned?
So for donor evaluation, we should go for the complete blood evaluation, along with the we'll check and monitor the blood pressure. We'll exclude any diabetes or pre-diabetic state. We'll take the eGFR of the patient. We'll confirm it by doing a DTPS scan, and we'll also check the number of arteries or veins present in the donor kidney, both sides. So which kidney has to be taken, and all these has to be, for donor's point of view, that should be kept in mind.
Okay. So
and urine examination techniques. So there should be no proteinuria. At least it should be less than 100.
What important anthropometric measure which will make you the donor unfit?
If the patient is obese with a BMI of more than 30, or in some
yes, donor obesity is a very, very important consideration in a live related donor. So you will be very, very careful. And also if the patient if the donor is morbidly obese or even overweight, you will give more time for the donor to reduce weight and come back and then do it, because this is it has been identified as one of the important factors which can have a say in the long-term prognosis of the donor. Okay, right. You went ahead and then you made a mention about some costly injections being given to him. So what is that? Possibly you are saying that it is ATG.
Yes,
so this ATG, are you in the habit of giving ATG for all haplo-identical donor recipient match?
Ideally, we should stratify the risk of the patient for having hyperacute or acute rejection in immediate post-transplant period, and accordingly we should decide whether ATG or bacillus should be given, or if there is no induction given. But in our institute, we used to give ATG to all patients, irrespective of the risk profile. For this patient received 2 units of blood transfusion during the dialysis period, so that makes him sensitized or alloimmune, sensitized to alloimmune.
So how does blood transfusion, what precautions you will take when you give a blood transfusion on a patient who is slated for a transplant?
Ideally, that should be a leukocyte depleted RBCs that should be transfused, but it's not available in our institute. We used to give the PLC.
So what is DSA?
DSA is a term that is donor-specific antibodies. So the antibodies, these are mostly the anti-HLA antibodies which are present in recipient serum against, and those are against the donor's HLA antigen.
So what is meant by DST? As postgraduates during the 1980s and 90s, I'm sure Professor Balla and Professor Gupta and all those would have involved themselves in DSTs. What are these? What is a DST?
Is it related
Donor,
to, I don't know exactly, sir.
this is a donor specific transfusion.
Specific transfusion.
So what was the history behind the donor specific transfusion and what happened to it? Why is it now given up?
So this was thought previously thought that transfusing the donor's blood into recipient, that will cause the recipient to have some kind of desensitization, and that will help in producing less amount of antibodies in the recipient's body. But subsequently, it has been found that the opposite occurs. The sensitization goes up.
Yeah, so after the era of the cyclosporin era, the donor-specific transfusions was given away. It was no longer practiced. So then you went ahead with the transplant, and the post-transplant period was reasonably good, acceptable, and you gave triple immunosuppression for this patient. And the patient, after 1.5 years of transplant, has come with a painless hematuria, isn't it?
Yeah.
So, okay. So, how will you approach this patient now?
So,
you do now?
Patient, yes. So I will definitely keep in mind that the patient might have a rejection episode. So initially I would like to take the tacrolimus level which is on, and see whether the.
You have done the tacrolimus levels twice, and you found that the levels were 8 and 6. Are you happy with the levels?
Actually, the level should be in the range of 4 to 6 after 6 months period. So if it is around 6, so I am okay with it.
So the levels, you are happy with the levels?
Yes, sir. 6.5 is now. Previously it was 8. So at that point of time, the tacrolimus dose was reduced, and presently it is 6.5. So
earlier the level was was 8, is it?
Yes,
the level the tacro dose was reduced, is it? Was there a deliberate reduction in the dose of the tacro by the treating nephrologist? Hello? Is there an audio disturbance? Hello?
Sir, voice is clear, sir. Audible.
Hello?
I think Naveen, the student, Dr. Ravi is not. Probably you request him to get himself reconnected. No?
Yes, sir. Yes.
Somebody else can also answer. There are a lot of people who are listening to it. So,
shall I allow it? If somebody wanted to speak, we can allow.
Yes, you please, you unmute and let the other students answer.
Yes. Correct.
A level of 8 nanograms of tacro with a good graft function, are you justified in reducing the dose of the tacrolimus? Anybody? Yeah, yes.
I was disconnected.
Yeah. So the level initially was 8. Was there a deliberate reduction on the tacro dose by the nephrologist?
Yes, it was done, sir.
Yeah. Do you think it is the right way to go?
Actually, in our institute, we used to keep the level of tacrolimus around 8 to 12 in the first 6 months, and then gradually taper it down so that the level comes down to 4.
So I think reduction of the tacrolimus dose may not have been warranted. So And the second aspect is the mycophenolate. What was the dose of mycophenolate which was given for him?
He is getting mycophenolate sodium of 360 mg.
What? How much?
Mycophenolate sodium 360 mg thrice a day.
3 times or 2 times?
Three times daily.
Okay, so supposing a patient is on cyclosporin and you give mycophenolate, and you have another patient on tacrolimus and you give mycophenolate, which patient will require a higher dose of mycophenolate and why?
The patient with cyclosporin, because cyclosporin prevents mycophenolate from in their from bile where it is secreted or it gets into the intrahepatic circulation. Here there is the protein MDR receptor like protein, so through which those are secreted. So that secretion is being inhibited by use of cyclosporin, and so the second peak of mycophenolate, which is usually occurs after around 6 to 12 hours of those given. So that doesn't occur. So we need a higher dosage in cases of cyclosporin.
Good. So that is a way to go. So mycophenolate dose can to some extent be on a lower level in when you use tacrolimus, in contrast to cyclo, where the doses cannot be reduced because of the blockage of the enterohepatic circulation by cyclosporin. So this patient, what is the next step that you will take?
So I'll do a urine routine and culture. We'll exclude some if there is any evidence of pyelonephritis, and we'll see whether there is significant proteinuria or not in the necrotic vein.
So this patient says that he has got dysuria and macroscopic hematuria. What are your thoughts?
This patient didn't have dysuria, but only macroscopic hematuria.
Macroscopic hematuria. Okay, yes. So what are your thoughts? What are the differential diagnosis of macroscopic hematuria in a post-transplant patient 1.5 years later?
So the differentials will be, one is definitely I would like to exclude pyelonephritis or cystitis. Second is if there is presence of stone in the graft kidney, if the patient is had any history of grapeluria or history suggestive of primary octaluria as a native kidney disease, they can have a recurrence of stones, or de novo stones can also be there in the graft kidney. Thirdly, if there can be we can have some lower tract problems, so that can give rise to like ulcerations, infections, mostly related to infections. Other than this, if there is any recurrence of glomerulonephritis, like IgA nephropathy in the graft kidney, that can
other than pyelonephritis, can you think of any other infection?
Yes, sir. That can be a fungal infection or BK viral infection.
Yeah, more than fungal infection, it is the BK virus which you will think of. Consider BK virus. Can it produce a macroscopic hematuria?
That can cause stricture in the lower urinary tract,
no, before stricture formation, it can very well produce macroscopic hematuria with cystitis. So hemorrhagic cystitis is a very well known phenomenon which can happen in BK virus. So you will also consider BK viruria in this patient.
Yes, I will also look for any if there is any episodes of rejection that can also give rise to macroscopic hematuria, specifically if there is any antibody mediated rejection and graft rupture. So these patients can have macroscopic hematuria.
Okay, so this patient had a biopsy. The biopsy reports shows that this patient has multiple crescents in the glomeruli, and also he has got the immunofluorescence has shown that there was IgA deposits in the mesangium of the graft without tubulitis or features of antibody mediated rejection. So what are your thoughts? So what will you diagnose now?
At this point, the diagnosis will be a recurrence of presentic glomerulonephritis, which is a presentic IgA nephropathy. It's probably the recurrence of the disease, and the basic disease of the native kidney disease was probably IgA nephropathy, or it can also be a presentic IgA nephropathy that the diagnosis was missed because the patient landed directly into end-stage renal disease.
So what will you think if the patient had an IgA nephropathy with crescents in the first instance and he has landed up in into you 1.5 years back before transplant? So what would have made you to suspect? The ultrasound, what clues you would have got?
So, relatively normal sized kidney, if it is a presentic IgA nephropathy, that can progress to ESRD, but the strengthening of the kidney that take a longer duration. So we can jolly well have a kidney biopsy at that point of time to find out what was the
in this patient, he had bilateral small size kidneys, telling you that unlikely that he had a crescentic IgA nephropathy as the presenting symptom in the first instance. So that is very unlikely. So in this patient, he has got a crescentic IgA. How do you differentiate this from a de novo IgA nephropathy?
As the patient has recurrence of disease within 1 year of transplant, so it's a very faster appearance of the recurrent disease compared to the normal IgA recurrence, which usually occurs around 4 to 5 years later, and they have a very slower progression. Even if there is recurrence, the progression towards the end-stage renal disease is very slow, and they land up into only 30-40% of those patients land up into ESRD in the next 4 to 5 years. So it takes a very long duration. But probably because of this is presentic IgA nephropathy, that's why that recurrence has occurred early, and the progression of renal dysfunction is fast.
And that brings us to the question as to the common primary glomerular diseases which have a propensity to recur, and how do you make a diagnosis in them? So what are the common primary glomerular diseases which high propensity for recurrence?
That is MPGN, C3GN, or dense deposit disease, the IgA nephropathy, and it's idiopathic form of FSGS.
So we'll go one by one. You said about the MPGN. What type of MPGN that you are talking about?
Both C3GN and dense deposit disease. Among these two, dense deposit disease is more notorious, and they have around 50 to 60% chance of recurrence, and most of the time they fail, around 80-90% times. Those recurrent disease causes graft.
Okay, so the next next disease that you are talking about is primary glomerular disease.
That can be C3GN also. That also has a 40-50% recurrence and around 50% chance of graft failure post-transplant. Other than this, IgA nephropathy and idiopathic FSGS, especially if the patient is having a malignant form of FSGS during the in native kidney. The malignant FSGS have a high propensity to have.
So now that,
as well as
okay. So there are other forms of diseases which are a relative contraindication for a mere kidney transplant alone. One of them is hyperoxaluria. So we will not consider that at the present context. We'll confine our discussion to the IgA nephropathy. Why do you think he has developed this disease at all in the first place? There is absolutely there is no family history. Is it common to have no family history in IgA nephropathy?
Sometimes familial clustering has been seen in IgA nephropathy, and they can have some associations with HLA. They can have HLA associations along with some other mutations like complement factor mutations or HORMAD. They can have.
Okay, the answer I expected from you is family history will almost always be negative in IgA nephropathy because it is not a monogenetic disease. It has got polygenic factors. Multiple factors are involved. The final answer as to why it happens is not very clear. So there are multiple areas where interactions occur. So what is the accepted pathogenesis now?
It is being told that this is a galactose deficient IgA1 that is abundant in the circulation, and it is mostly produced from the malt cells in the terminal ileum or some other peripheral lymph nodes or terminal centers, as well as bone marrow. So, and there is antibody production against this galactose deficient IgA1. So these antibodies can be of both IgG or IgA type, and these antigens and antibodies, they combine to form immune complexes. They circulate and get deposited in the usually in the mesenterium, and because of their charges and size, and they causes mesenterial hypercellularity and proliferation, and finally they lead to molecular changes. So like activation of local complement or reactive oxygen species and additive molecules like these, and they cause
what is anatomically why mesangial cell is more prone for all these immune complex depositions?
That is one is because of their position, that is between the capillary loops and the Bowman space. So while the immune complexes traverses through the capillary loops to the Bowman space, they pass through the mesenterium, and if the size is the immune complexes is very big, they can have a high potency.
So I expected an answer from you saying that mesangial cell directly interacts with the endothelium. If you take a cut section of the glomerulus, you will find that there is no basement membrane between the mesangial cell and the endothelial cell. So that is the basement membrane is not there. That is why you will have more interaction of the mesangial cell in every form of glomerulonephritis. Most of the forms, they are more prone. The second aspect is that mesangial cell receptors are specific, seems to be predilection of these complexes. IgG and IgA complexes seem to have a predilection towards this mesangial cell. So what type of complement is specially activated in IgA nephropathy?
It's lectin binding MBL mediated complement pathway.
What is this? Tell me about this lectin pathway.
So these are activated. This pathway is activated by the presence of mannose binding lectin or some IgA.
No, where are these lectins present? What are lectins?
Lectins are cell surface molecules that act like
lectins are not cell surface molecules. The lectins are proteins. These proteins have a mannose binding property. The mannose binding, where is the mannose? Where is
present in the bacterial
yes.
or cell wall?
Yeah. So lectins are circulating proteins. They have a collagen stem, and from where the protein ficoles, they are actually called fibrinogen collagen molecules, which are circulating in the blood, and they have a specific property of acting like an antibody. So they bind to an antigen, which is the mannose, which is present in the cell wall of the bacteria. So what gets activated after that?
They merge with the alternate complement pathway, and directly C3 can be activated.
So in contrast to the common thinking that it goes through the alternate complement pathway, it is the classic complement pathway which is being stimulated in lectin binding. The lectin, once it is bound to the mannose, then there are what are called serine proteases. Serine proteases. What are called mannose serine proteases, MASP, and these act like a C1Q, not like C1Q, but R and S. So they actually activate the classic complement, and C4 is activated, and so it goes through the classic pathway of activation. So that will deposit C4D. Sometimes you can have a deposition of the C4D also in IgA nephropathy. Then this once this is activated and the disease goes up. So what are the Indian data? Can you tell me an Indian publication which followed the IgA nephropathy patients over 5 to 7 years and charted their progression of renal disease, and what was their findings? A large Indian database was created, which is large by Indian standards because this was published 5 to 8 years ago. So a CMC Vellore did you have a go through that paper?
No,
so it is very important that you know what is being done in our country. So you should go through that paper, which is published in Nephrology, Carlton, possibly in 2005 or 8, and that gave us an very good information about more than 400 IgA nephropathy patients, and the findings are damning that the progression of renal disease is much faster than in a Caucasian population. So much so that the authors have said that we have to designate the Indian IgA nephropathy as a malignant IgA nephropathy. So that is a very important take-home message, that in the Indian context, IgA nephropathy behaves in a much more malignant way, and many of them are caught only in the end-stage renal disease. So now you have done the transplant and there is a recurrence, and you have started giving, you have stopped MMF, and cyclophosphamide is added, isn't it?
Yes, sir. Yes.
So what is the evidence base for such an approach?
It is based on the evidence, mostly on the native kidney disease of eccentric IgA nephropathy. That is Stop IgA trial that has shown the use of cyclophosphamide along with steroids. That has probably the
So we are walking on thin ice now, because we don't have a great evidence base for use of cyclophosphamide, but there are only individual case reports of cyclophosphamide being used in crescentic IgA nephropathy post-transplant, and there has been some success. So this is how this was possibly that would have given rise to this type of case management in this patient. So what are the possibilities that this patient is going to have a normal renal function after cyclophosphamide therapy, and what would you advise the patient?
In spite of having high immunosuppression given, the chance of having a normal renal function will be around less than 50%. So there is a high chance that he will progress towards ESRD again and will need a renal replacement therapy in the form of repeat transplant or dialysis or peritoneal.
So what will you, supposing the patient does not recover and his creatinine goes on mounting, and after say 8 weeks of cyclophosphamide therapy, you are nowhere, and the creatinine is now 8 or 9. So what will you do?
So I'll have if there is a significant urinary symptoms or volume overload, I will keep the patient temporarily on maintenance dialysis, and will start reducing the immunosuppression level. Only if there is significant residual urine volume, I will continue with immunosuppression, but with a very less dose, will continue prednisolone of 5 mg, and will stop mycophenolate and gradually taper tacrolimus over the period of next 4 to 6 weeks, and then we will continue with preparing the patient for the repeat transplant.
The answer should be, I will stop once 8 weeks are over and absolutely no response and the creatinine is mounting. I will stop cyclophosphamide first, and then and then start on a course of tapering of the CNIs. This tapering, because this patient has had a transplant only for the past 1.5 years. This graft has been there for 1.5 years. Can you go ahead quickly, reduce it, stop it, and then put him on dialysis? What are your thoughts?
If the patient is, I will not consider graft nephrectomy for this patient unless there is any graft intolerance syndrome. And as I am keeping the graft, and so I will consider to continue with, and if I will counsel the patient if he can go for the second transplant. If he is planning for a transplant in next 6 months to 1 year time, I will better continue with the immunosuppression, at least steroids, and will stop tacrolimus.
So I think tacrolimus is stoppage is not the way to go when you are especially considering within 6 months of stopping a second transplant, supposing there is a donor available. So you will go for a low dose, possibly once a day tacrolimus, and also a small dose of steroids in this patient, and go ahead. And supposing you are going ahead with a second transplant and you are not removing the first graft, so what specific surgical instructions that you will give to your urologist as far as the vascular anastomosis is concerned?
So as the first graft is preserved, so we have to go to the opposite side for anastomosis. That has to be done on the left side, as it is in the right iliac fossa. So left-sided anastomosis has to be done.
Okay. So what anastomosis you will, the first, the arterial anastomosis was done with, supposing this was done with an internal iliac artery anastomosis, what specific information, the instruction that you will give a urologist about the anastomosis in the second kidney, and why? Anybody from the can raise their hands and tell me.
That has to be done in the external iliac.
Yeah.
Because
why?
If both-sided grafts are in the internal iliac, that will cause severe hypoperfusion to the organs of the pelvic organs, and that will cause severe pelvic pain, and there can be impotence, especially.
So this is very important. Vasculogenic impotence is danger when you have a bilateral internal iliac artery anastomosis. So this is a very important thing that you will discuss with the surgeon, and ask him to have the anastomosis on the external iliac artery. And then what type of immunosuppression that you will give for this patient in the second transplant?
For the second transplant, I will definitely go with ATG. We will check the donor-specific antibodies if there is present or not, and then we'll go with the induction of ATG, and followed by that, I will continue with the.
What is your thought on the second course of ATG in a patient who has already received it?
So that the total cumulative dose of ATG should not be go beyond 10 mg per kg doses. So he in the first transplant probably has got a total of 3 mg per kg. So we have a scope to keep ATG again. But that can have a effect on the long term that can cause malignancies post-transplant. So we have to keep close watch on it.
Okay. So what about your concern about steroids?
Patient,
you will give steroid-free immunosuppression?
No, sir. I will not consider steroid-free regimen, but we'll definitely consider to taper the steroid dose rapidly over the period of next 2 to 3 months, and keep him on around 5 to 10 mg per day, 10 mg per day.
Okay. So very likely that this patient is going in for a progressive renal disease, and unlikely that he is going to respond well to the cyclophosphamide, and we are staring at a second renal transplant. You will go for a related transplant, or you'll wait for a cadaveric transplant?
As there is a recurrence of GN within 1 year of the transplant, so it's better to have a disease donor transplant. So that will help in reducing the terms of recurrence post-transplant.
Yeah. So, so what is the incidence of panel reactive antibodies when you have a long waiting time with a failed graft in a patient like this? Supposing you are waiting for 3 to 4 years.
Panel, I didn't get
Yeah.
the question.
So the panel reactive antibody, the incidence of panel reactive antibodies in such patients who are waiting for a cadaveric transplant with a failed graft in situ.
There is a high chance that he will have a high PRA level of around more than 50%. That is possible for the second transplant.
So that is an issue that you will have to contend with. So supposing this patient has got a high PRA levels, so and you have a graft, you have a cadaver which is coming up tomorrow possibly, and what will you do? He has got a PRA, panel reactive antibodies are positive.
Immediately I will go for the CBC crossmatch and flow cytometry, both for this patient who is going for a second transplant, and if as well as we will check the HLA. If there is we can go for a virtual crossmatch if the SAB bioluminescence method has already been done for the recipient, and we can take the high resolution of HLA parameters for the donor, so that we can do a
so you will if it is possible, which may not be possible in all the situations, if you have a center which is very well known to have the antibody levels tested for the patient and also match it with the HLA of the cadaver, find that there are matches which are good, so you can go ahead, then you can go ahead with good chance of survival. So that is how you go ahead with in a cadaveric transplant situation. So I think we have discussed almost all the points. I have a couple of slides which I wanted to project about the recurrence of the transplant, the primary glomerulonephritis with respect to transplant and with importance given to IgA nephropathy. So I'll just share my screen and then we'll go through that. Thank you. So Amesh, is it visible?
Yes, sir.
Yeah,
Yes,
we
sir.
can,
Yes.
we can see.
Okay. So this is a recent article which came in the Kidney International from the Mayo Clinic. They have done a good job of looking at all the recurrence in the graphs of more than 1,500 graphs. And they've seen that amongst the recurrences, and IgA nephropathy were towering over the other causes of glomerulonephritis as the most common cause of recurrence. And as you go through the years in the first year, second, third year, fifth year, you can see that there is a progressive increase in the chances of recurrence. This is possibly brought about by the fact that many of these are due to protocol biopsies or biopsies which are done on demand. So as far as the IgA nephropathy is concerned, the first year recurrences are as low as 12%. And by the fifth year, you can see that almost 50% there is a recurrence. But the important issue that we have to understand is that not all is lost when you think of a recurrence, that the graft survival seems to be excellent. So and recurrence is not equivalent to graft failure. So you should have that positive mindset in your mind and then go ahead and manage these patients to the best of abilities, giving them all the best coverage with antihypertensive and also ACE inhibitor or ARB therapy in these patients. The second aspect is that when you compare the hazard ratio for the graft failure, the IgA nephropathy is not such a benign disease at all. If you compare it with membranous nephropathy, the hazard ratio is much more in IgA nephropathy than in membranous nephropathy. It is very high in MPGN and intermediate in FSGS. So the immunosuppressive protocols and recurrence, we don't seem to, the current immunosuppressive agents used in transplant don't seem to reduce the IgA recurrence in the allograft. And ATG seems to give some cause for cheer because it seems to reduce the chances of recurrence. These are all single center experiences. And as far as the survival of recipients with IgA nephropathy when they receive a cadaver versus a live donor, it has been shown that the live donor seems to do less well than the cadaver. And especially in the ANS data, the Australia-New Zealand registry data, in zero HLA mismatched living donor grafts, very, very high chances of recurrence. So if you have if you know that somebody has got an IgA nephropathy and a sibling is coming forward to donate the kidney, and if you find that the IgA, if you find that the HLA is 100% matching, don't be very happy and then go ahead with the transplant. Very, very important fact is that there is a very high chance of recurrence. So this is one area where you will have to think again and weigh the pros and cons before going ahead. So when you have 100% HLA, zero mismatched graft, especially coming from a sibling, think again if you have a biopsy proven IgA nephropathy in your patient. So this is again another Oxford data which tells us that when you have C1q, which is deposited in the mesangium of the graft, the chances of worsening graft function is going to be very high. And this is the meta-analysis of almost all the data which has been collected on the IgA recurrence. So we have data from close to 4,000 IgA nephropathy recurrences, that the recurrence rates are close to 20%, and the median time to recurrence is close to 4 years. And the graft loss due to recurrence is not very high, it is low. But one caveat is that when a patient has got a crescentic IgA, then the graft loss is going to be very high. So in the John Hopkins experience, they have close to 104 patients where they have published again a couple of years ago. 19% of the grafts had recurrence. And the important aspect is the living related donors and younger age at transplant. So this patient was young and he had a living related donor. So these two are very important. The other aspect is that in this patient, there was a proteinuria, or there was a hematuria. A typical macroscopic hematuria as the presenting symptom of a recurrence is not a very common occurrence in IgA. In fact, it is proteinuria or mild graft dysfunction. So only 40 to 50% of patients with IgA recurrence had typical hematuria as the presenting manifestation. And you have to understand that class 2 matching seems to have no bearing on whether an IgA recurrence is going to occur. So it is only the class 1 which is very important. Class 2 matching doesn't seem to have a great bearing. And another important aspect, as you correctly said, is that steroid-free immunosuppression seems to increase the risk of recurrence in IgA nephropathy. So you will rather not do a steroid withdrawal or a steroid-free immunosuppression in this patient when you are going ahead with a second transplant. What are the, if you are supposing you are practicing in the US and you want to see whether this patient has got a high recurrence chance, if you check the anti-galactose deficient IgA1 prior to transplant, possibly it may give some prediction on the recurrence. In the same way, serum IgA levels at 6 months, these are all single center studies. Serum IgA levels 6 months post-transplant, if it is levels are above 222 at month 6 post-transplant, the recurrence rates were higher. Then again, a publication from Madras where 2 consecutive recurrences of crescentic IgA in a renal transplant from Dr. Gopalakrishnan's unit. Also, you have to read. So the risk factors for IgA recurrence or the donor risk factors, live donor more than the diseased donor, and a full house HLA match is a no-no for a typical IgA nephropathy whom you are planning for a transplant. As far as the recipient, the younger age, the HLA B8 and DR4 seem to have a higher risk of recurrence. Rapidly progressive glomerulonephritis as the presentation, and non-use of ATG induction and steroid-free regimens, they all seem to have an aggressive course. In recurrent IgA, as is being seen, as is being given in this patient, oral or even IV cyclophosphamide on a monthly basis for 6 months. Some case reports or individual case reports are there where they were able to create or they were able to salvage the graft function. So you can also look at intravenous cyclophosphamide on a monthly basis in these patients. So the takeaways from this patient is that the longer follow-up, more frequent allograft biopsies uncover recurrent IgA nephropathy with higher frequencies. Risk seems to be higher with a better HLA matched kidneys, and hematuria as in this case, is less common as a presenting manifestation of recurrent IgA. But crescentic IgA is rare, but has got a bad prognosis as far as the allograft survival is concerned. And second transplant can be carried out with a variable risk of recurrence, and you shouldn't lose your heart. You can think of a second transplant even in this patient. I think I'll stop with this, and then we'll have some discussion.
Thank you, Dr. Sampath. You have discussed this case in a detailed manner, and very, very practical tips you have given for all students. See how to differentiate CKD from this interstitial disease from glomerular disease, and then importance of intradialytic hypertension. Very important, like 44-hour ambulatory BP monitoring. And Dr. Rajiv Agarwal, he is the authority actually on this. He has done a lot of work on hypertension in dialysis patients. And then the role of median on that is on Wednesday, you do this study, and systolic blood pressure of more than 140. Then about drugs, which drugs to use in dialysis patient for as antihypertensives. Then he has highlighted about dry weight. I'm sure you will note these points because these are the tips which you will not find in your test books, and only an experienced teacher can tell you about these. And then about recurrence, that even when there is a recurrence, we know still the transplant is the best option. And that message is there. And don't forget that obesity is a very, very important risk factor in a donor. So that you have to highlight whenever you are working the donor. Then next is about recurrence. He has discussed in detail about recurrence, and very glad that he has done all the efforts to make a presentation and very, very practical tips in his presentation. About he has stressed on mesangial cell, how it, why it is important in IgA nephropathy. Then another very important, how to stop, decrease immunosuppression once patient is reaching dialysis. That is very important because you are going to prepare for second transplant. So that's why he has highlighted that tacrolimus low dose and low dose steroids should be continued in these patients, and maybe MMF can be stopped. Then DST, as he mentioned during our teaching, and that was a routine thing. We used to give 3 DSTs to patient before doing transplant, and how the things have changed. But historic things also you should remember, because the examiner is going to ask what is DST. Sometimes you may not be knowing the full form of DST also. So that is very important. And he has obviously related to the case, he has shown given the presentation. And I'm sure all of you you have gained from this thing. There were 245 total registrations, and Zoom viewers were 110, and YouTube viewers were 10. So many students have learned from your excellent bedside teaching today.
Thank you.
Thank you very much. And I'm sure in future also you will agree to our request.
Yes.
So whenever we request you for class.
Thank you.
And what is your assessment of the candidates, sir?
Yeah, he is good.
Okay.
He is passing.
Good. So congratulations, Ravi. Continue your hard work, and soon you will get the good news about the examination.
So you have to send me the sweets when you pass.
Definitely.
And for your information, all these recordings are there available on the YouTube. You can always go through these presentations, whatever bedsides we have discussed so far.
Oh, nice.
So this is very good.
Thank you, sir.
Thank you, Dr. Sampath.
Thank you, sir.
Thank you, sir.
Thank you.
So, Dr. Balaji, so
yes,
just wanted to once again thank all the students for having spared their time in the morning, and particularly Dr. Sampathji and Dr. Balaji for having spared their valuable time on Monday, first thing in the day. So thank you very much, sir, and I'm sure we will be adding more and more value addition in the days to come. So I request all the students to stay connected on every Monday. And as Balaji has rightly mentioned, we are available on the YouTube. All the 10 editions, the 9 editions are already available. This edition also will be uploaded in the next 2 days. So I look forward to your views in the YouTube, and kindly share your comments. And if there are any interesting suggestions, we'll be more than glad to attend. So thank you, Dr. Sampathji, Dr. Balaji. Thank you very much. Dr. Raviji, thank you very much. Have a good day, sir.